Thank you. Thank you for the introduction. Ladies and gentlemen, I'm here to give you a talk on our limited experience on catheter closure of PDA using MFO. I'd like to thank my colleagues in the Philippine General Hospital for making this presentation possible, including Dr. Dexter Chang and Dr. Luisa Go, who shared their cases in this presentation. My disclosure slide. In our country, MFO is primarily being used to close ventricular septal defects. The cost of this device is twice the regular PDA occluder, so we're pretty much selective in using it in RVSD cases and occasionally in coronary artery fistula cases. But every now and then, we get to use our MFO. As described a while ago, these are the characteristics that make MFO a suitable PDA device. It's quite soft, low profile, which in fact can be used, can be advanced to a guiding catheter. It has two discs with an articulated waist, which can be screwed on either side, so you can do an antegrade or retrograde approach. There's a slim delivery cable, and you combine that with a guiding catheter, making the delivery system quite light, which is very beneficial in the patients that we actively use this. The clots is present in sizes 7, 9, and bigger. So the other devices have no clot in it, from 8, 6 and smaller, and it is easily retrievable. So in our resource-limited setting, we try to consider MFO in symptomatic infants who are less than 5 kilograms, mostly 4 kilos or less, but not less than 2 kilograms. It is also a possibility of using this in hypertensive PDAs, because the disc in the RV side of this occluder, which is originally thought of, or which will be in the PN, will prevent it from embolizing to the aorta in cases of acute pulmonary hypertension or pulmonary hypertensive crisis. Also in small PDAs in larger patients, which can be hard to cannulate antegradely using a retrograde approach, you can also use this as long as the ampulla is big enough to accommodate the device. And also in some long tapering PDAs, you have to note though that the PDA cannot be a straight tubular PDA because the retention disc on both sides cannot be inside the PDA. As mentioned, this is what was included in the device. Just to show you that up to 8.6, we can use a 5 French guiding catheter when we deploy an MFO for PDA occlusion. And then from 7.9 downward, we will use a 6 French. The disadvantages, it is quite soft, although it makes it very malleable and it conforms to the shape of the PDA. It can easily melt out if you're not too careful, and if you try to pull it too hard, it can easily pull through. And in some situations, it can embolize to the pulmonary artery, especially if you undersize it. There is a potential left pulmonary artery stenosis because of the relatively big disc that sits in the pulmonary end. There's also a potential for rotation of the aorta if you use this in tubular PDAs and the retention disc or the disc on the LV side sits in the aorta. And because of the absence of the clot inside, there is delayed total occlusion for PDAs which are 8.6 or below. Some of the representative cases that we have, this is the first case is an 11-month-old, 3.2 kilogram with failure to thrive. There is a left ventricular enlargement. The PDA on measurement, this is a type A PDA with a 6.2 millimeter PAN, an ampulla of 11 millimeters and a length of 8 millimeters. We use a MFO 97 through a 6 French guiding catheter. This is the aerial projection of the PDA, the actual deployment. We can shoot through the guiding catheter, especially if it's a 6-French guiding catheter, the PDA to check for LPA stenosis. We can also, of course, use a PDA catheter to check the descending aorta to make sure that the disc will not cause coarctation in the aorta. The second case is a 3-week-old, 4-kilogram infant who has intractable heart failure and had a complication of pneumonia, which could not be weaned from the ventilator. So we decided to close it with MFO again 9/7 through a 6-French guiding catheter. The PDA was sized at 6.1 millimeters with an occluder of 11 millimeters. In terms of sizing, what we usually do is we measure the narrowest diameter, and we had about 1 to 2 millimeters. And the limiting factor, of course, is the size of the ampulla, because in small infants, coarctation might be an issue. So we're always concerned about the disc that sits in the pulmonary artery, because it's sometimes quite big. And so we try to push it as much as we can to plaster it at the wall of the pulmonary artery, trying to make sure that it's not sitting or not obstructing the left pulmonary artery. Third case, again, is a 4-kilogram, 11-month-old with frequent respiratory infections, with pulmonary hypertension, left heart enlargement. The PDA was relatively long, it was about 10 millimeters, although it was tapering with a narrowest diameter of almost 4 millimeters and an ampulla of 8 millimeters. We again use a 9/7 with a 6-French DR for guiding catheter. These are the measurements. Fourth case is a 9-month-old, 4-kilogram, slow weight gain, frequent respiratory infection. PDA, which is relatively small, it's only 2.8 millimeters with an ampulla of 6 millimeters and a length of 4 millimeters. We use a small MFO, a 6/4, which was delivered to a 5-French delivery sheet. So in our institution, if we have infants who have PDAs and they're asymptomatic, since it's quite expensive to use the MFO, we will actually wait for them to reach a certain weight, wherein we can use a bigger delivery system if we need to. So we try to reserve our MFO cases for symptomatic infants. After about a few weeks of observation, we could not, they were quite symptomatic and there's really failure to gain weight. And the last case is a 13-kilogram, 3-year-old boy who came to us with a mild coarctation based on 2D echo, relatively asymptomatic. The PDA was 3.2 millimeters with an ampulla of 6 millimeters. An MFO 8/6 was used, although looking back, we probably could have used a smaller one, which was used, which was delivered to a 6-French sheet. So here on the lateral angiogram, you can see posterior indentation. Although there was no significant gradient and a relatively small type A PDA, we use an 8/6, I think, based on availability. And we just try to pull the device as far from the aorta as possible. And pressure determination showed no significant cohort. The plan was to follow up on this case, and just in case the patients develop coarctation, we can actually do balloon angioplasty or even put a stent sometime down the line. And lastly, I just want to show you the one important, probably advantage of having this in the PDA in situations where you have a hypertensive PDA. That this is a relatively large PDA wherein there is a big PA disc preventing, or at least will not allow the device to embolize right to left, which can be a problem or a nightmare. So, in summary, in our setting, MFO as a PDA occluder is being used in small infants with large PDAs, hypertensive PDAs wherein pulmonary hypertensive crisis may occur, long tapering PDAs, and small PDA via retrograde approach. MFO currently is not being used for tubular PDAs and the